Alrighty, guys. Next up is our trauma scenario. Um, Not a whole lot really changes as far as scene size goes and primary impression. We'll talk about that as we go. Big thing for trauma scenarios, these are our motor vehicle collisions, these are our assaults, falls, um, things like that, sports-related injuries, so on and so forth. So as always, with any of our calls and skills, we're doing PPE. For our size up for this, like I said, for MVAs, we want to get a windshield view. We want to make sure that we have good access, good egress. We want to assess the scene to make sure that there's no safety hazards for being able to get to the patient, getting the gear to the patient, and understand again that all of our scenes are dynamic. So there's always the potential of a safety issue happening. So we need to make sure that we're aware and that we're using our best judgment to basically be able to say that, hey, if something does come up, we need to step off until our scene is safe. For motor vehicle collisions, we need to remember our additional resources, or just trauma scenarios in general, we need to remember our additional resources. If this is an MVA or an assault, we want to make sure that we have our law enforcement dispatched as well for crowd control, traffic control. For our assaults, we want to make sure that the assailant has been either detained or is no longer present. We want to make sure that we have the law enforcement body there so that if someone were to come back in, that we are considered safe at that point. And that way law enforcement can take care of that. We want to determine how many number of patients we have and do we need any additional medical assistance as well. So either additional ambulances, fire department presence, what's our mechanism of injury? If this, again, a motor vehicle accident, which is what I'm giving the most examples about, is this a patient that's going to need a lot of extrication time or require specialized equipment that the fire department has? Are we going to need extra manpower to help stabilize vehicles, help extricate patients out? Other medical resources that we have are going to be additional ambulances, additional rescues, additional intermediate ambulances, additional ALS ambulances, helicopters. All things that we need to be taking into consideration for these types of calls. Request these resources early so that by the time that you're there, they're also dispatched in that way that it's kind of a fluid motion as far as being able to get patients off scene in a timely manner. With trauma, these are the ones that we definitely want to consider our C-spine precautions. High MVA or high-speed MVAs, anything that's got a high mechanism of injury, we need to consider C-spine on. These are the patients that we're going to also probably do backboarding as well. So, with the primary survey, again, that doesn't really change a whole lot, or the primary assessment doesn't really change too much between medical and trauma. We want to, as we're approaching the patient, we want to know how they're positioned. Are they tracking us? Are they talking? Are they talking to other people? Are they alert to other people? And kind of go down the same steps. So if this patient's in this car on the ground, we want to, assess what their level of consciousness is. Sir, can you tell me what's going on? If the patient is awake and they're tracking me and they're talking to me, we can assume that they are alert. We can dive more into that as far as being able to ask alert and oriented questions, ask what happened. It's another way to be able to help judge with mentation as well. If they are asleep, we want to talk to them. We want to see if they were responsive to a verbal stimuli. So this patient's not able to track us and is not awake. Sir, can you tell us what happened? If they respond to that, they're alert to verbal. If they're not alert to verbal, we can do kind of a trap pinch, or we can squeeze the nail bed, or we can do kind of a sternal rub. If they respond to that, then they're now alert to a noxious stimuli or painful stimuli. If they're not responsive to that at all, they are U on the APU and they're unresponsive, which means we need to probably escalate or be expeditious with this call. Once we've determined the level of consciousness, we need to check for any life threats, any bleeding or anything like that. Bleeding from the head, anything like, we need to just do a rapid assessment, make sure that there's no active bleeding that could possibly cause death. We need to see if there's any other injuries with that as well. For trauma, we need to, instead of doing airway, breathing, circulation, we switch to circulation, airway, and breathing. So we want to assess where their pulses are at. Do we have pulses at the radial? If they're unconscious, we'll start with the carotid. We want to see, do they have pulses at the radial? If they have pulses at the radial, they'll also have them at the brachial, they'll have them at the carotid. If you have absent, work your way up. Do they have brachial pulses? Do they have carotid pulses? Airway, if this patient is laying supine and we think this is a trauma situation, we need to be doing the jaw thrust maneuver instead of the head tilt chin lift. And also be holding manual C-spine stabilization and getting them into a C-collar. We have a video on that one as well. So if they are unable to open their airway and we think this is a trauma situation, we don't want to mess with their C-spine too much, we'll have our partner hold direct inline stabilization. They'll be supine at this point, and then we will do what is called the jaw thrust. So right at the back of the mastoids, we're going to push up, we're going to open the airway, and we're going to assess if there's any secretions, obstructions, anything like that. We'll fix it, we'll treat it, we'll move on. From there, we'll move on to breathing. So we're going to want to get into the respiratory, or make sure that they're breathing with adequate depth and effort. We want to make sure that there's bilateral chest rise. We'll get a respiratory rate real quickly, but we want to know if they're breathing fast or slow. If they are breathing fast or slow, then we need to fix this, and then we need to move on. And then at this point, we also need to assess skin condition and then make a transport decision based off of this. For trauma, we like to get off scene within 10 minutes as far as the golden rule is concerned. So from here, if they are sitting upright, they're alert, they're talking to us, hold manual C-spine stabilization, we'll size them for a C-collar. We can go through that all in the other video for C-spine. And then we need to get them moved over to a backboard, secured, and get them going. And as we are doing the assessment, we can also be talking to our patient as far as what happened, what's their past medical history, what's their meds, what's their allergies. So that way we're kind of getting a good picture early on, so that way whenever we're initiating transport, we can start doing our more in-depth assessment. So once we get them onto the backboard or into the truck, we'll move on to our head-to-toe assessment. Now is kind of the point where we're going to get into our head-to-toe assessment once we start getting the patient, once we start initiating transport, getting the patient off scene. Again, like I said, golden rule for trauma is that we want to get the patient off in about 10 minutes. Seems like a really short period of time. It really is, but our goal is to get them to definitive care, which is the hospital. So for doing a head-to-toe, at this point, we should have a basic set of vital signs that will include your blood pressure, your pulse, your respiratory rate. Start working on getting your sample history. As you are doing this, we can start working on your head-to-toe assessments. We've already gotten through just a real rapid sweep, making sure we've corrected any life threats, but at this point, this is where we would be reassessing that, but also trying to find if there's any other injuries that we can report to the hospital. So again, gloves are still on. The patient will more than likely be in a C-collar and on a backboard. Before we backboard them, we want to make sure that we've done a sweep of their back. We'll cover that in another video for you guys. But at this point, they should be secured to a backboard on the gurney, transport, or en route to the hospital. So head to toe, we start literally head to toe. Take your gloves and hands. You're going to feel for any deformities, any crepitus, any soft spots. We're going to look for any external bleeding. From there, we're going to move up to the forehead, cheeks, jaw. We'll have them open up, stick their tongue out. Again, we'll reassess the airway at this point. We're going to get a pen light. We're also going to check pupil reaction. We want to make sure that the eyes are equal, round, and reactive to light. Look at both ears. We want to make sure that there's no bleeding. We don't want to make sure there's any secretion coming out of the ears. We want to make sure they can hear on both sides. Working our way down to the neck, we want to palpate the C-spine, which should have already been done before being placed in a C-collar. We want to feel the neck. We want to make sure that our trachea is midline. We're also looking for any jugular vein distension. From here, we're going to start going down to the clavicles. We're going to make for stability in the chest, shoulders, chest itself. We're going to feel ribs. We're going to check the sternum, make sure that the sternum is in place. Working our way down to the abdomen. And also typically in trauma, the patient will be trauma naked. So going on to the abdomen, we want to feel all quadrants. We're checking for any rigidity, any pain. We'll go through all 4 quadrants. Working our way down to the pelvis. We want to make sure that the pelvis is stable. Do a rock test. Do the open book, kind of bring inward pressure and then kind of let go. If the patient is trauma naked, we also want to make sure that genitalia is intact, there's no bleeding or anything like that. Going on to the lower extremities, we want to do a rock test on the thigh, making sure that we're not feeling for any swelling, any deformity or pain. Work our way down to the lower leg, same thing, rock test. We want to go down to the feet. We want to check for pedal pulses. Also want to check for CMS. We do this on both sides. Check CMS on both sides. As we're doing the upper extremities, same thing. We're going to do the rock test. If we can, and there's no deformity, we can have them bend their arm. Also checking for stability. We're checking radial pulses. We're checking CMS. We're doing that on both arms. So assessing the back, again, this is a trauma patient. Patient should be on a backboard, but quick overview on that before we put them on a backboard. So you'll have your partner holding midline stabilization, manual stabilization. Should be in a C-collar at that point. With your partner at the head, you're going to follow their commands. So what they're going to command, that we're going to log roll them. So like I said, we do this before introducing the backboard. So pretend there's a backboard in front of me. Partner at the head is going to give me a count of 1, 2, 3. And we're going to log roll. At this point, kind of expose the back. We're going to start going all the way up. We're checking for any type of deformities, abrasions. We're going all the way down the spine. We want to make sure we check the flanks as well. Once we're done doing, also we want to make sure that we're checking the shoulders. Once we've done finishing our back assessment, we would introduce our backboard, and then on my partner that's holding C-spine, we'll count 1, 2, 3. We'll bring the patient back onto the board. Also, other things we do need to be checking, we do need to listen to the lung sounds. As you're at the chest and we're checking for chest rise, go ahead and take a listen to the lung sounds. Make sure you're hitting the tops and the lowers in the axillaries. As you're also progressing down, also check your pulses, check your carotids, check your femorals, check your brachials, check your radials, check the pulses in the lower extremities as well. At this point, like I said, if there were any injuries that were considered a life threat in your primary blood sweep, we want to make sure that we're reassessing, make sure that those haven't been exacerbated or anything like that. And then continue on with the rest of your assessment, your vital signs, your history taking, and continue on transferring.